Okay, everyone. So we are going to continue with where we left off with the MCQs. Question number 31. You all have 1 minute. The timer starts now. Raise your hands once you are ready to answer. Dr. Sneha raised hand first, and then Dr. Zubeda, Dr. Manisha. Sorry about that. Let me correct the. Okay, here we go. Dr. Sneha, you can start your answer if you're ready.
We saw the answers.
That was for number 30, not for this one.
Oh. Option D.
Option D, okay. Dr. Zubaida, do you want to add something?
Yes, I agree.
You agree with it? Okay. Dr. Manisha,
I agree with D.
you agree with D? Okay. Anyone else? Dr. Sedana?
I think it should be B.
Option B? Okay.
B.
All right.
No, Caesar, I think hypertonic yesterday we did. Yeah.
Okay. Dr. Sedana, why are you choosing B or D?
D.
D. Okay, hypertonic. Okay.
Yeah, because of C.
Why aren't we giving her normal saline right now?
It's Caesar's, right?
It's acute hyponatremia with serious or severe symptoms like seizure. So in this case, we correct it quickly with hypertonic saline. I think everyone got it. Sorry. Why is my mouse is okay? Let's go to number 32. Timer starts now. Dr. Sneha number 1, Dr. Zubaida number 2. Dr. Manisha is number 3. 20 more seconds. Dr. Sedana is number 4. Okay. Dr. Sneha, you can answer first, and then we will move on to the next.
Option B.
Option B. Okay. Dr. Zubaida, do you agree with her?
I choose option A.
You choose option A. Okay, good job.
Because the salinity is low.
Yes, sodium is low. Dr. Sidana, do you agree with?
Yeah, it's the B SIDH. So fluid restriction is the treatment.
Fluid restriction is the treatment. Okay.
For the SIDH.
Yeah. Okay. Dr. Manisha, do you agree with them or do you disagree?
I think it is IDH.
What is the cause of her or his low sodium?
Small cell cancer.
IDH.
SIADH. Good job.
Yes, syndrome of inappropriate. So in here, so we can choose B as a baby.
B. Okay, good job. Dr. Mahbuba, you wanted to add something?
Can I change my option? Because the patient euvolumic. And there's no normal. Yeah. I will go with
Yeah,
D.
the patient.
You want to go with A?
Okay, I choose option A.
Option B?
Okay. I want to go with A.
With A, you want to give them hypertonic saline. Okay. What do we have the case here of? What's the case?
SIADH,
SIADH due to?
Euvolemic hyponatremia.
Okay.
Due to malignant.
Okay. Hypotonic hyponatremia. Because serum osmolality is low, so sodium level is low, and they are euvolemic. So euvolemic hypotonic hyponatremia due to SIADH secondary to small cell lung cancer, probably. Their symptoms are mild. They have nausea and headache, and it's been going on for 1 week. Remember, if it is going on for more than 48 hours, we do not use hypertonic saline bolus. In those cases, we correct it slowly. Now, slow correction can be through restricting fluids, free fluids, or through normal saline. This looks like a case of CR or SIADH. In SIADH, first we try fluid restriction. Since he doesn't have seizure, he doesn't have any serious or severe symptom right now, we would restrict their fluid, free fluid intake or just water intake and see how they do. If their sodium level goes up or if it's staying down, then in that case we can consider normotonic or isotonic fluids, not hypertonic. We wouldn't give them 3% because it's chronic hyponatremia. Okay. Yes, Dr. Manisha?
I always mix this, but I want to correct it tonight. So in this syndrome, it means there's no loss of nitrogen because we absorb more water and the serum is more diluted. That's why there's hyponatremia. Am I right?
Yes.
Okay. Thank you.
No problem. Moving on to the next question. Timer starts now. Raise your hands when you're ready to answer. Okay, Dr. Sneha first again. Dr. Gursharan, Dr. Manisha, Dr. Zubeda. Okay, good job. 30 more seconds. Dr. Sneha, you can read the question and then answer.
I was going for option E.
Okay. Why
As
did
it is like diarrhea and dizziness, so it is like hypovolemic hyponatremia. So the first line of the treatment will be normal saline infusion.
Okay. Dr. Gursharan, do you agree with her?
Yeah, I agree with her. It's E. Yeah.
Okay. How about Dr. Manisha? Do you agree with her?
Yes. E.
Okay. Okay. Does anyone disagree?
I agree with option E.
Option E. Okay, good job. Yeah. Let me see. Okay. I'm trying to figure out how to make the participants appear on the screen instead of on the side. Okay. Dr. Paul, yeah?
E.
E or
Yes.
M? E, okay. If you look at the case, 54-year-old, 3 days of profuse diarrhea and poor intake. Right now, dizzy when standing, which means orthostatic hypotension, low JVP, and tachycardia. And their sodium level is 128. Now, serum osmolality is also low, so it's hypotonic hyponatremia, but based on low JVP, tachycardia, and orthostatic hypotension, it is hypovolemic too. Urine sodium is 8 millimole per liter. What's the single best treatment? In this case, we would have to give them normal saline, not only to correct the sodium, but also to correct the hypotension, because this could be the starting of hypovolemic shock. That's why we would have to give them sodium, normal saline, regardless of the sodium level at this point. And it's been 3 days, so after 48 hours, hypertonic cannot be given. Fluid restriction is for CAD, not for loss-related hyponatremia. Loop diuretics will make hyponatremia worse. Okay, I think everyone got this one. Options, timer for the next one starts now. Raise your hand when you're ready to answer. Sorry. Dr. Manisha, Dr. Sneha. Dr. Gursharan, Dr. Sedana. Okay. Okay, Dr. Manisha, you can answer.
A as an apple.
A as in apple. Okay. Dr. Sneha, do you want to add anything?
Yeah, A, because we can't do the rapid correction because it can lead to central pontine hemolysis, demyelination. So that is,
Demyelination, okay.
yeah.
Um, and sorry, Dr. Sedana, Dr. Gursharan, sorry.
Yeah, I'll also go with A.
You also want to go with A?
Yeah.
Right.
Yeah,
Dr.
A, it's A.
Sedana? Okay.
Yeah, A.
Yeah, this is more of a theory thing, but remember our goal is to keep it less than 10 millimole per day. We wouldn't correct it more than 10 millimole per day, since that can cause worsening of the confusion and give them another seizure if they haven't gotten one already. All right, let's move on to number 35. Dr. Sneha first. Okay. Dr. Zubaida is number 2. Dr. Manisha is 3. Anyone else want to try the questions? I know we all make mistakes. There's nothing to be worried about. Dr. Gursharan is number 4. Dr. Dr. Sneha, I know you raised your hand first. Let's give Dr. Gursharan a chance. Is it okay?
Yeah, sure.
Dr. Gursharan, you can answer the question.
So this is C, collect sodium for glucose.
Okay. Dr. Manisha, do you agree, disagree, want to add something?
I was thinking of A.
Okay. Why were you thinking of A?
So the patient has polyuria, polydipsia, and dehydration.
Okay.
No, I'm wrong. Okay.
Dr. Zubeda, do you want to add something?
It's the patient have a case of hyperglycemia, and even there's the ensure, and also the patient is dehydrated. We started with sodium, lisotonic. Option C.
Option C. Okay, good job. Dr. Paul, do you want to add something or do you disagree with anyone here?
No, it's okay, doctor.
Okay, Dr. Sneha, what were you going to choose? Option A, B, C, D?
Option C.
Option C?
Yeah.
Okay, why not A?
Because for this, this is not I was choosing this for option C because there is like shift of water from intracellular to the extracellular. So that is the first we need to treat, then the decay, and I don't think there is any ketone high or anything in here. So
Okay.
And also glucose is low in here. Glucose is 32.
Glucose is 32, so wouldn't that
it is
be
still
DKA?
hyperglycemia. Not the
Isn't it?
decay. It's
Uh,
hyperglycemia, but not the decay.
not DKA. In DKA, what else would we see?
Ketone, ketonuria,
Ketonuria. Okay.
and cause for respiration as well, cause for breathing.
Okay. And what would happen to
Anion gap,
anion
metabolic
gap? Okay.
acidosis. Yeah.
So we will see anion gap metabolic acidosis. Um, Here the other data is not given, so it's too little data to judge it as DKA. But look at the patient's age and symptoms. Age is 59 and they're presenting with polyuria, polydipsia, and dehydration. So it's most likely type 2 diabetes. And in type 2 diabetes, DKA is uncommon. It doesn't happen until very late. It can be hyperglycemic, hyperosmolar state, but not DKA right now. So A would be wrong for that reason. Hypertonic saline bolus, we won't give it right now because patient has very little symptoms of hyponatremia. The first thing we would do is correct the sodium for glucose. Like I said, for every 100 milligram above 100 milligram per dl, we add 2 to sodium. Now, if we are doing it in millimoles, let me use my phone's calculator, or I can use computer's calculator. So 1 millimole of glucose is considered equivalent to 18 milligrams. So his blood glucose level is 576. If we minus 100 from it, so it will be 4.76. And if I multiply that by 2, we would have to add 9 to his sodium. 128 plus 9.5, that would make it about 137.5. So his sodium or low sodium is not true hyponatremia. It's because of the hyperglycemia. That's why we would correct sodium for glucose. And he doesn't have any symptoms, so we treat the hyperglycemia. Sodium would become normal once hyperglycemia is controlled. We will move on to the next question. Timer starts now. Okay, this is again a hyponatremia approach that's, I think, available on your accounts. Please read this, use the slideshow, anything. Try to understand how to approach it, and then you won't struggle with the MCQs. Moving on to question number 36. Timer has started, sorry. Dr. Sneha raised her hand first. Okay. Dr. Manisha is number second. Dr. Sabzubeda is number 3. Dr. Mahbub is number 4. Okay, Dr. Sneha, you can answer if you're ready.
Option D.
Option D. Okay, Dr. Manisha?
A as an apple.
A as an apple, okay. Dr. Zubaida?
Option D.
Option D.
Because the patient have generalized seizure
Mhm.
and also hot weather.
Okay, timer is up. Dr. Mahbuba, you wanted to add something?
Option D.
Option D?
Sorry, option E.
E, okay.
Yeah.
Um,
Because she has a generalized seizure.
Okay, and what is tolvaptan? We can't hear you, Dr. Mahbuba.
Sorry, today my connection is not good. I said option E.
Yeah.
Because the patient has the generalized seizure, and also the serum level is it is hyponatremia.
Yes, it's hypernatremic. You want to choose E. What is E? What does it do? Okay. I think her internet's having issues. So tolvaptan is a medication that is an antagonist to receptors of ADH. It causes free water diuresis. So if we give this to someone, they will lose water. It's a good, reasonable option to choose here. However, remember, she had seizure. If someone has hyponatremia, yeah.
The patient drank too much water.
Yes. However,
and it dilute the sodium level.
Yeah.
And it causes hyponatremia and seizure.
Okay, you're right. However, seizure is a severe feature of hyponatremia. Acute hyponatremia with severe features, we correct it quickly with hypertonic saline. We don't wait for water for tolvaptan or fluid restriction. I hope that helps. Okay, moving on to number 37. Timer starts now. Dr. Manisha is number one. Dr. Sneha raised hand second. Dr. Sedanis raised hand number three. Okay. Dr. Manisha, you can answer. We have 15 more seconds left.
A as an apple.
A as an apple, pseudo-hyponatremia artifact. Okay. Dr. Sneha?
Yeah, A.
A. Dr. Sedana?
Yes, it's A. It's A.
Okay, option A. Dr. Stella?
Option A.
Option A, good job. Why not B, C, D, E? Dr. Sneha, what's the case talking about?
I only saw in the chart that triglyceride and everything in the flowchart, so I remember in your lecture it was option A. So.
Okay. Remember, like we discussed in the lecture part, hyponatremia or low sodium with normal plasma osmolality. This is 290. It is borderline, but still normal. It's usually due to an artifact such as high lipids or high proteins such as beta light chains in multiple myeloma, etc., or aldosterone gamma globulinemia. In those cases, the protein or triglycerides, they kind of make the plasma dilute by absorbing more water from the extravascular compartment. However, since they are in higher concentration, plasma remains normotonic or isotonic. Sodium goes down. All right, let's move on to the next one. Remember, so in CRT, they would be hypotonic with euvolemia. Cerebral salt wasting, it is similar to CR, but just the mechanism differs. In cerebral salt wasting, usually due to head traumas or hemorrhages, they lose more salt because of natriuretic, which causes natriuresis. Primary polydipsia, there is no mention of them drinking lots of water. So if they are not drinking lots of water, it doesn't exist. Once again, in primary polydipsia, it would be uh, hypotonic because of dilution. Adrenal insufficiency, it will cause hypotonic euvolemic hyponatremia. Question number 38, timer starts now. Dr. Sneha and Dr. Zubeda. I'm sorry, I didn't see who raised their hand first. We will give Dr. Zubeda a chance since Dr. Sneha has been answering all the questions first. 30 more seconds. Time is up. Dr. Stella and Dr. Zubeda, you can answer.
Okay. Option C.
Option C. Good job.
Yeah.
Dr. Sneha and Dr. Stella, do you guys agree with her?
Yeah.
Okay. I think this was a repeat from the last question, so we can skip over it. Okay, question number 39. Dr. Sneha raised her hand first. Mr. Zubeda. Okay, Dr. Stella, you can Dr. Sneha, you can answer. Sorry.
Option E.
Option E. Dr. Zubaida.
Yes, I agree.
You agree with her? Okay. So once again, we have a case of CRT, patient with small cell lung cancer. Symptoms are mild, nausea and headache only, and it's been for 1 week. Right now, he's euvolemic, JVP is normal, there is no edema, sodium level is 126, osmolality is low for serum, urine osmolality is high, sodium in the urine is 60, which is high, more than 40. So what is the single best initial management? Restrict their water intake, and then we can see how it goes, all right? Okay, timer starts now. Okay, Dr. Sabzaveda is first, Dr. Sneha. Dr. Manisha. Okay, Dr. Zubaida, you can answer.
Yeah. I'll go to the option B.
Option B.
I'm not sure. I'm not sure.
It's fine. Dr. Sneha?
Yeah, option B, hypovolemia, hyponatremia for 3 days. So B.
Option B, okay. Dr. Manisha?
I agree with B.
You agree with B? Okay. If you look at the question, it's because of diarrhea and poor intake, which means that
That's right.
the body's sodium is down. We need to replenish it. So since it's been 3 days, we cannot give her 3%. We would go to normal saline. And orthostatic dizziness, tachycardia, and low JVP, like I said earlier, they can be signs of an impending hypovolemic shock. So we would have to give normal saline regardless. All right.
I have a question, Dr.
Yes.
You mentioned about the urine sodium as 8 millimole per liter. What is the meaning of this? It is like perfusion of the kidneys low?
No. So if someone has hyponatremia, we expect their sodium to be below 40 or below 20. Below 20 is where we put the cutoff. If it is higher than 40, we then consider issues with kidneys reabsorption capabilities. If it is lower than 40, specifically lower than 20, it means that kidneys are reabsorbing enough sodium, but the person still has hyponatremia. Sodium excretion less than 20 millimole, that's what we would see in someone who is normal, but they are low on sodium in their plasma levels. Okay.
At this time, the urine concentration will be changed.
Urine concentration will be, so if urine sodium is low, like this is 8 millimole here, the urine will be more dilute. So it means that their kidneys, everything is working fine. It's just poor intake that's causing their low sodium.
Thank you.
You're welcome. Moving on to the next question. Okay, timer starts now. Raise your hands when you're ready to answer. Okay. Okay, Dr. Zubaida, Dr. Sneha. Dr. Joseph, Dr. Chris, Dr. Marcel, Dr. Paul, Dr. Sonia, I think. You can also participate. It's okay if we aren't sure what the answer is. Try to reason out which one is incorrect, and then you can select the correct one. Dr. Saizubeda, you can answer.
Option C.
Option C, okay. Dr. Sneha?
Option A.
Option A, okay. Why A and not C?
Hyponatremia, hypotension, but hyperkalemia. So it can lead to adrenal crisis. So I go for A.
Does anyone disagree with her or want to add something here? Okay, good job, Dr. Sneha, and good job, everyone. So remember, adrenal insufficiency, usually it would be subtle. Sometimes it would cause vomiting, abdominal pain, nausea, fatigue, and in this situation, if they get an infection, someone who already has adrenal insufficiency, they can go into adrenal crisis, which has hypertension, hyponatremia, but hyperkalemia. Treatment of choice is IV hydrocortisone. We do not wait for anything else to work. We give them IV hydrocortisone because they are deficient in steroid hormones. The electrolyte imbalance, it is due to the adrenal crisis or the adrenal insufficiency. So we don't give them levothyroxine, we don't give them saline, 3% saline bolus. We do not restrict free water in this case. We don't give oral tolvaptan because it's not ADH related. It wouldn't do much. The only thing we can do here is to give them IV hydrocortisone. Remember, once again, I want to reiterate on one point. 3% saline is for hyponatremia with severe features such as seizure. If seizure and acute hyponatremia is present, you give 3% saline. Otherwise, it's not used routinely. Moving on to the next question.
Sorry, Dr. Sfayos.
Yeah.
In some cases about the acute adrenal insufficiency, they mention about recently surgery or like this.
Yes.
In this case, we don't have, and this during the reading, I don't attention to the hyperkalemia because it's like a difficult in like this case. But Sinaha has really good explained this case: hypotension, hyponatremia with hyperkalemia.
This is adrenal insufficiency, or in this case, it would be crisis because of the profound fatigue and vomiting.
Thank you.
No problem. Remember, in exam, they will never tell you it's adrenal insufficiency or Down syndrome or Cushing syndrome. They will give you features like this, and they won't give you the full clinical picture. This is why MCQS is very hard. They give you 2-3 symptoms, and they want you to think and pinpoint what's the abnormality. Unfortunately, this is how exam is going to be. So make sure you are getting used to questions like these ones. Okay, question number 42. Let's try someone who hasn't answered yet. Dr. Paul did participate. Dr. Oliver, do you want to answer? Or Dr. Abiuddin?
I'm at work. I'm just listening.
Oh, okay. Okay, no worries. Dr. Joseph, Dr. Marcel, does anyone among you want to try? Dr. Paul? Okay. Dr. Paul, you can answer the question if you're ready.
Yes, I'm going for G.
For what, sorry?
G, like day. Thiazide diuretic.
Okay. Okay. Good job. Does anyone disagree with option D? No one? Okay. Dr. Manisha, do you want to tell us why D would be correct?
Yes, because hydrochlorothiazide is a diuretic and it acts on distal convoluted tubules.
Yes.
And due to this, we lose the sodium.
Okay, good job.
That's why it's hyponatremia.
Thank you, Dr. Manisha. Dr. Sneha?
Yes.
Okay. Tough question for you. Why is it not primary polydipsia? All the points that make it unlikely.
I think the urine osmolarity is less than 100 here, and it is more than 100 in primary polydipsia. I think. I'm not sure.
Okay. We don't have urine osmolarity. Okay. Does anyone want to state?
I mean the urine sodium one. It's 55 here. It should be more than 100.
Yes, urine sodium is 55. in primary polydipsia, what happens is the person is drinking lots and lots, and usually 6 or 5 or 4 liters of water, and that's what causes the hyponatremia, because everything gets diluted by the excess water. So they would have dilute urine. Kidneys would be functioning normally. Their sodium would have been normal if they hadn't drunk that excess amount of fluids. Okay. Why is it not heart failure? Because in heart failure, you would see signs of hypervolemia or fluid overload, such as edema, JVP raised, etc. In pseudo-hyponatremia, you would have hyponatremia because of high uh, levels of lipids like triglycerides and proteins, with isotonic hyponatremia. Here, hyponatremia is hypotonic. Remember, see this low serum osmolality? So it's hypotonic hyponatremia. Now, in untreated hypothyroidism, you will get again, you will get hypotonic but euvolumic hyponatremia, and their sodium in urine would not be this high. It would be normal or low. Since urine sodium is more than 40 with low serum sodium, this means that there is an issue with the absorption of sodium from the distal tubules or from the collecting ducts from the kidneys. So the only thing that would cause issues with reabsorption is thiazide or diuretics. Moving on to the next question. Timer starts now. Okay, let's say, so whether you can answer if you're ready. I think this is
Option B, primary polydipsia.
Primary polydipsia. Good job. Dr. Sneha?
Yeah, now I got this option B.
Option B. Good job. Okay, so what differentiates this primary from SIAD? You said it earlier. In SIAD, there will be one thing of the urine.
Oh, the urine sodium, it says here low, and there it will be more than 20.
Yes. And earlier you mentioned urine osmolality. Here, urine osmolality is
70. Yeah, 70.
Yes, in CR, remember, osmolality is more than 100,
100.
not less than 100. Less than 100, primary polydipsia. More than 100, it's
SIAD.
SIAD.
Yeah.
Okay, moving on to the next question. Timer starts now. Dr. Zubaida raised her hand first. Dr. Sneha, Dr. Manisha, Dr. Pez, Dr. Marcel, please participate. It's okay if you're unsure of the answer, or if you have any issue, just type in the message that there is an issue that you can't participate. Thank you. You also. Dr. Sedana, please refrain from answering in the chat. It is, I need just 5 minutes, be back. Okay, thank you, Dr. Manisha, for letting us know. You will be getting them a hint towards the answer. Okay, Dr. Zubaida, you are the first one to raise your hand. Go ahead and answer the question.
Option A, the case of heart failure. Okay.
Okay, heart failure. Okay.
Yeah.
Dr. Sneha?
I go for E.
Option E. Okay.
Yeah.
Dr. Mahbuba?
Option E, because the patient has systolic heart failure, dyspnea and leg swelling, and also the elevated GVP. That's why I'm thinking about loop diuretic therapy.
Loop diuretics. Okay. Wouldn't loop diuretics make the sodium worse?
Because the patient has lots of fluid in the body. So
Yes.
We need to drain some amount of water in order to maintain the sodium level in the normal level.
Yes, you're absolutely right. Here, if you look at the signs, he has heart failure, and now he has dyspnea, leg swelling, JVP is raised, which means that he has acute worsening or acute decompensation or congestive symptoms. So in this case, our goal will be to flush the excess fluid. That's what we do with loop diuretics. And in addition to that, we will give them IV saline. We want to lower the fluid inside the, we want to address the fluid overload, also correct sodium level. All right, let's move on to the next question. Okay. Timer starts now. Dr. Sneha is the first to raise her hand. Dr. Sneha, you can go ahead and answer.
I think this is C.
Option C. Okay.
Yeah.
Does anyone want to add something here? Okay. You're right, Dr. Sneha. This is a case of euvolumic hypotonic hyponatremia. Euvolumic hypotonic hyponatremia most commonly happens because of CARD, but remember CARD is diagnosed after excluding adrenal insufficiency or hypothyroidism. The only option here that matches that is cortisol. It will help us in determining if patient has adrenal insufficiency. Ketones, urine culture, D-dimer, troponin, they won't give us any diagnostic value at this point. Timer starts now. Dr. Sneha raised her hand first. Dr. Zubaida, second. Okay, Dr. Sneha, you can answer if you're ready.
Option B.
Option B, okay. Dr. Zubaida, what's your answer?
Yes, the case of post-surgery, and we can't stop all IV if the meaning of fluid. Okay. Otherwise, if the patient is oral, the option B is correct.
And is correct, okay. Dr. Sidana, do you agree with option B or do you want to pick another one?
Urine osmolality is high, 600. Okay. That was dehydration.
Dehydration, okay. So do you want to give her saline?
I think, yeah.
Okay.
A choice.
Option A or C then?
A.
Option A. Okay. Dr. Manisha, yeah, you want to add something?
Yes, I think it's the SAID syndrome, if I'm not wrong. And I will go with B as a baby.
Yes. It is CR'd, but here the mechanism is slightly different. Remember, what are some triggers for ADH? Does someone know?
Oh, the first one is surgery.
Surgery for
Yeah.
not CR'd, for ADH secretion.
Sorry, could you repeat that?
For ADH secretion, what stimulates ADH secretion in the hypothalamus? Or ADH production, sorry, in hypothalamus.
Hyponatremia.
Hyponatremia, okay. Does someone want to answer something differently or add something here?
So during the surgery, when we lose more water, so that's why it stimulates that one, and this sometimes it disturbs more.
Okay.
And this could be a cause of it.
Okay. Yeah. Dr. Sneha, you were trying to say something?
Oh, hypoglycemia and sometimes the stress related to post-surgery can be one of the trigger factor as well.
Okay. Normally, what's the main trigger for ADH secretion or release?
Dehydration.
Dehydration. Can you be a little more specific? Like how?
So when when we lose some water,
Yes.
so this trigger ADH.
Okay, you're absolutely right. Normally, the trigger for ADH secretion is concentrated plasma or high levels of solutes in the cytoplasma compared to the fluid level. That's what triggers the hypothalamic production and release of ADH. But there is one other very important trigger. It's very strong, which is nausea. Nausea also makes the body produce more ADH. Here, she has nausea, remember? Persistent nausea. That's why she has CR'd. ADH is inappropriately released because of nausea. Despite low sodium, her body is producing more ADH than normal. And the urine osmolality, so serum sodium and serum osmolality, they all match that secretion of the excess of ADH, which causes more water reabsorption, and sodium is not reabsorbed, so which makes urine concentrated, serum diluted, and hyponatremia. Okay, we will move on to question number 47. Timer started. Thirty seconds. Okay, time is up. Who wants to give it a try? Whoever made the graffiti on my screen, can you try it? Dr. Manisha, you want to try it?
Yeah, so maybe it's asking for prevention of seizure. Am I right?
Mm-hmm.
What is the single best next step to prevent neurological injury?
Okay.
So I believe B.
Option B.
Yes.
Okay. Dr. Sneha, Dr. Siddhana, Dr. Stella, anyone else want to try it?
I think this is option D.
Option D. Okay. Why?
What is D, by the way?
DDAVP, it's a shortcut that we use for desmopressin or a synthetic form of ADH.
Okay.
Yes, Dr. Stella? Dr. Stella, you can open your mic if you're ready.
It's D.
Option D. Okay. Why are you choosing D and not C or E?
I'm choosing D because D is going to slow down the rise in sodium to a safe level.
Yes. Thank you. That's what I was looking for. If you look at his hyponatremia, it is chronic. His baseline is 118. So we start him with isotonic saline, right? But in 6 hours, his sodium raises to 126. So it is a change of 8 millimoles. And we said we do not try to raise more than 10 millimoles per day. So it is rapid recorrection. Rapid correction, we have to dilute plasma again. How do we dilute it? We give them desmopressin or ADH to reabsorb water. We give them dextrose water to increase the plasma volume with fluids, or dextrose water is basically free water. Okay, that's why D is the correct option. If you continue the isotonic saline, you're going to give them demyelination injury. If you can give them 3% saline bolus, you will give them demyelination injury quicker. If you add furosemide, you're going to give them hypotension, plus you risk giving them again the demyelination injury. Oral tolvaptan, it will cause water diuresis, so it will make the correction more rapid, which is again going to give them demyelination injury quicker. Moving on to the next one. Please remove this signature, whoever did it. Question number 48, timer started. Okay. I think now we're getting to the interesting questions. Okay, Dr. Sebzabeda is the first one to raise her hand. "30 more seconds. Dr. Sedana is number 2. Dr. Sneha is number 3. Okay, we will wait a few more seconds. Dr. Sebzabeda, you can answer.
Option A.
Option A?
Because of subacute rash?
Yes.
In the case of trauma.
Yes. Dr. Sedana?
I think it's the same. Yeah.
Yes, you think option A is correct, right?
Right.
Okay. Why is C8 wrong here, Dr. Sedana?
Because in that the orthostatic hypotension with low JVP.
Yes. What would that mean?
Developing signs of hypo
volemia. Okay.
Yeah.
Dr. Manisha, you wanted to say something?
Yeah, I think one of the differences that in SIADH, the level of sodium is more than 100. Am I right? Urine sodium.
Urine sodium is 80 millimoles per liter. Oh,
in SIADH, is it more than 100? Am I right?
That is CRT, that's urine osmolality, not sodium.
Urine osmolality, yes.
Yes. So,
okay.
Please stop writing on the screen, whoever it is. Okay, just give me 1 second. Let me. Okay. Okay, so remember, if someone has hyponatremia and it is hypotonic, I hope everyone can understand my writing. It's really bad with the mouse. Let me try removing the connector. Hypotonic hyponatremia with normal volume status. So it becomes two things. Either it is CAD or it is primary polydipsia. Okay, now in CAD, the mechanism is excess of ADH and antidiuretic hormone. It stops diuresis or loss of water. So it causes excess water reabsorption, and that's how the plasma gets dilute and sodium gets dilute. This is how CAD causes hyponatremia. But since ADH is high, they're reabsorbing more water than sodium. What happens to the urine in CAD is that urine concentration goes high, or level of sodium in urine, it's high, because the amount of sodium being reabsorbed does not match the water that's being reabsorbed. In primary polydipsia, everything goes dilute. It is because of excess fluids. Kidneys are doing their job well, so if kidneys are working fine, they will dilute the urine to save sodium and excrete the water. I hope this makes it clear. For CAD and primary polydipsia, remember, sodium in both will be low, both will have normal volume status, both will have low osmolality of plasma or serum. Difference would be in urine. In CAD, their urine is concentrated because they are not reabsorbing enough sodium due to the excess of ADH. So the water excreted has more sodium in it. Now, in primary polydipsia, everything is in excess. Water is in excess, which causes the plasma volume to uh, expand. This lowers down the sodium. This lowers the plasma's osmolality, or the amount of concentration, the concentration of the plasma's solutes. And in return, what happens, the kidneys try to compensate by making dilute urine with low sodium and low urine concentration. So for CAD, the urine concentration is the urine concentration is usually more than 100 milliosmol. But in primary polydipsia, the urine concentration will be less than 100 milliosmoles. All right, hope this helps. Let's move on to the next question. I'll try to quickly remove this. Okay. Question number 49. Okay, timer starts now. Okay, no one has raised their hands yet. Okay. Dr. Sneha is the first one to raise her hand. Dr. Manisha, number 2. Dr. Zubayda, number 3. Okay. 15 more seconds. Dr. Sneha, you can read the question and answer it.
I go for option E.
Option E, okay. Dr. Manisha?
I agree with E.
E. Dr. Zubayda?
Yes, E.
E, okay. Dr. Sidana?
Yeah, same E.
E, okay. Good job. So once again, remember 81-year-old living alone, eats toast and tea. Poor protein intake, so it's likely that her sodium intake is also low. Mild confusion, unsteady gait, these are symptoms of low sodium. So her sodium is 124, serum osmolality is low, so hypotonic, hyponatremia. Urine osmolality is 80, which is less than 100, and sodium is low in urine. What is the cause of her hyponatremia? So sodium, urine osmolality less than 80 with low sodium in the urine, CRD is ruled out. Thiazide will cause high sodium levels in urine. Thiazide is ruled out. In adrenal crisis, similar effect would be seen. The osmolality of urine would be higher. They will also have hyperkalemia, remember. They won't just have hyponatremia. Hyperkalemia would also be there, and they will have hypotension. She doesn't have hypotension, just confusion. Heart failure. In heart failure, again, urine will be dilute. It wouldn't have 80 milliosmol osmolality, though. It would be higher than 100. Low solute intake, similar to excess water. In low solute intake, what happens is plasma gets diluted. It makes sodium, the person is not taking enough sodium, so they don't have enough sodium to reabsorb enough water and keep enough volume in the intravascular compartment and into the extracellular compartment. So what happens is they're losing, they do not lose sodium in urine. They do not lose excess sodium in urine, do not use sodium through the GI tract. The cause of hyponatremia is low intake. Their urine is dilute, less than 100 milliosmol, which is very dilute urine, similar to what you would see in primary polydipsia. We will move on to question number 50. Timer. Let me start the timer. Dr. Sneha, number 1. First to raise hand is Dr. Sneha. Okay. Dr. Sneha, you can answer the question.
Option C.
Option C. Okay, good job. Remember, this is severe hyponatremia, but it is chronic, so we cannot correct more than 10 millimoles per day. 8 millimoles per day is where we would target. So our target would be around 8 millimoles. We can target 10 millimoles if we are sure that patient is tolerating it well. Moving on to the next question.
Dr. Faz, if there will be option 8 and 10, then what would we choose, 8 or 10?
Then that would depend on your own judgment, honestly. It depends on sodium levels, how long they have had it, and how likely they are to tolerate it. Remember, if someone is 49, they're relatively younger, they can tolerate 10. But if it was an 89-year-old, you cannot do 10. For them, it would be 8.
Okay. So, for instance, if there is option 10, then we would go for 10, not 8.
10 would be for those who can tolerate it. 8 would be for those who are unable to tolerate more than 8.
Okay.
Yeah, it would depend on the clinical scenario, so it would be very specific. I don't think they will test you that deep in nephrology.
Sorry, thank you.
Yeah, no worries. Okay, so this is a flow chart by Dr. Chella. How do you address someone with hyponatremia? So okay. If someone has low hypernatremia, sorry, not hyponatremia, hypernatremia, how does it happen? The mechanisms are either that they are not drinking enough water or they're losing more water compared to sodium. Reduced intake, someone who is elderly, they usually eat a lot, but they don't, sorry, not eat a lot. Someone with not elderly, the patients with dementia, they usually tend to eat, like if you give them food every 1 hour, they will eat it every 1 hour. But water, they're not really that keen on water for whatever reason. Someone who has swallowing difficulty, so swallowing difficulty such as in achalasia usually is starting with liquids and then solids, compared to tumors, which starts with solid, progressive dysphagia to solids and then liquids. Someone who has stroke, someone who is bedbound, what happens is that they are losing water in excess of what they're losing sodium, and they're not taking or drinking enough water. Their blood sodium level goes up. This is how hypernatremia develops in them. Now we will go on to some cases of hypernatremia. Timer, let me start the timer. Question 51, timer starts now. Raise your hands when you're ready to answer. I don't have these notes in my account. This slideshow is for the class teaching purposes. I don't think you will have access now. Okay, Dr. Sneha is the first to raise her hand. Dr. Zubaida. Dr. Sneha, you can answer.
Option C.
Option C, okay. Dr. Zubaida?
Yes, option C.
And C, why not A? It's hypernatremia, right?
Dextrose, 5%.
Dextrose 5%. Yeah, why not give them dextrose 5% since it's hypernatremia, not hyponatremia. They have more
Patient is
sodium than water.
dehydrated.
Sorry?
The patient dehydrated?
Yes, thank you. Patient is dehydrated. They have signs of hypovolemia, tachycardia, or a state of hypertension. Correct volume, sodium level will normalize. Correction would be with normal saline, not with dextrose water. Time starts now. Dr. Sneha, Dr. Zubaida, okay. Dr. Agnes, If you want to participate, please raise your hand so we can give you a chance to speak your mind. Okay, Dr. Gurshan, welcome back. Okay, Dr. Sneha, you can go ahead.
Option E.
Option E as in Edward or
Elef
A as in apple?
E for elephant.
E for elephant. Good job, Dr. Zubaida. What do you think?
Yes, the case of surgery and transsphenital area.
Yes.
And central diabetes insipidus.
Kindly give us 30 seconds to see the question and answer, please. Okay. I go off on when someone raises their hand. I just say their name, that they're 1, 2, 3. You can raise your hand whenever you're ready, and I will give you a chance either to answer the question or I will ask you a follow-up question about the topic. Dr. Gursharan?
Yeah, I'll also go with E, central diabetes insipidus.
Central DI, okay. Why is his sodium high?
Because it's causing fluid loss.
Fluid loss, okay.
Mm-hmm.
What is causing the fluid loss, sorry?
Because of the diabetes insipidus.
Okay. Because of diabetes insipidus, he is losing
Not
fluid.
retaining water.
Not retaining water. Yeah. Yes, Dr. Zubaida?
Because of increase of level of ADH.
Increase, okay.
Antidiuretic.
Antidiuretic hormone, yes. So in pituitary surgeries, the risk of posterior pituitary getting injured or getting destroyed or getting resected is high, and posterior pituitary is where ADH is okay. So posterior pituitary is where ADH is stored after it's been produced by the hypothalamus. Once the surgery destroys posterior pituitary, what happens is that they become deficient on ADH. Now, this deficiency of ADH translates to more water loss compared to sodium. So their urine is very dilute and they exhibit symptoms of diabetes mellitus, similar to diabetes mellitus, which is thirst, polyuria, polydipsia, not polyphagia, polyuria and polydipsia, along with losing free fluid. This causes a raise in the plasma's sodium level, and even if the sodium level is high in the plasma, they're still producing dilute urine because there is no ADH to reabsorb the water and make the urine concentrated. All right, so the correct option here would be central diabetes insipidus due to pituitary surgery, cutting off the supply to posterior pituitary or destroying it. Moving on to the next question, Dr. Ignas, option E is correct, central diabetes insipidus. All right, let's answer this one. Timer started. I would skip over this question. It's beyond the level of QE1. Total body water deficit calculation. It's not for NCCQE1. It is for year 1 and 2 residents to calculate. If anyone wants to answer regardless, you're free to answer, otherwise I'm skipping. Okay, so I will skip over this question. Let's do question number 54 instead. I'm restarting the timer. Okay, Dr. Zubaida raised her hand first. Dr. Sedana. Okay, 30 more seconds. Dr. Sneha. Dr. Joseph, Dr. Gurshan, Dr. Joseph, Dr. Stella. Good job, everyone. Okay. The time is up. Dr. Zubair, you can answer.
Option D, nephrogenic diabetes insipidus.
DI. Okay. Dr. Sidana?
Yeah, same nephrogenic DI. Means
Nephrogenic
sodium.
DI. Okay.
Yeah, sodium and lithium, they're same channels for excretion.
Okay. Dr. Sneha?
No, option D.
Option D. Okay. Dr. Joseph? Dr. Gurshan, sorry.
Yeah, option D, nephrogenic diabetes.
Okay.
Yeah.
Why is it not central DI?
It does, because this looks like lithium induced injury, and yeah, and it's not related to any brain tumor or anything, so it's nephrogenic. Yeah.
Dr. Joseph, is there any other point that points towards nephrogenic versus central DI?
Yes. So if it was central, when we apply to give desmopressin, it will help.
Yes, thank you for that. That's what I was looking for. In central DI, when you give them desmopressin, it helps. Dr. Manisha, do you want to add something?
I think I have this, nothing more.
Okay, thank you.
I want to add something if you want to.
Yeah.
The patient is bipolar and under chronic lithium. And one side effect of lithium is nephrogenic diabetes insipidus, because the kidney didn't respond to the antidiuretic hormone. And the case how to diagnose, it's desmopressin administration test. If there's some change occur, it's maybe central diabetes insipidus. If it's not changes, it shows that the patient have nephrogenic diabetes insipidus.
Thank you. Okay, everyone agrees. Remember, in central DI, when you give them desmopressin, their urine osmolality, it goes high, even 400, 600 can go really high with desmopressin administration, because desmopressin in central DI is the treatment. They're deficient in ADH. Desmopressin is kind of replacing that deficiency. So their body restarts reabsorbing water and their urine becomes concentrated very quickly. So this is a way to differentiate nephrogenic from central. Remember, nephrogenic does not respond to desmopressin since kidneys are not kidneys do not really respond to the hormone. The hormone is present, but regardless of that, if you give desmopressin to someone with DI, in both cases, the urine osmolality will go high. In DI nephrogenic, it will be a very mild change, but in central DI, it will suddenly shoot up very high. So remember, if someone with suspected DI and you give them desmopressin, if there is a dramatic rise in urine osmolality, it means central. If it is a very minute or no effect on the urine osmolality after desmopressin is given, This means nephrogenic DI. The kidneys are not responding to ADH, even though ADH is present. All right. Moving on to the next question. Okay. If anyone wants to see the answer, this is the answer. Timer starts now. Okay, Dr. Sneha, Dr. Zubaida, Dr. Sidana, 3. Sneha, Dr. Sneha, you can answer.
Option B.
Option B. Okay. Dr. Zubaida?
I agree. Option B.
Option?
Option B.
B. Okay. Dr. Sidana?
Assist B, osmotic diuresis because of hyperglycemia.
Diuresis. Okay, good job. Why is it not pseudo-hypernatremia? Remember, pseudo-hyponatremia exists,
right? Because patient, so it's in hyperosmolar hyperglycemic state patient. So it because of the osmotic diuresis, glucose is withdrawing the water along.
You're right. This is hypernatremia. In hypernatremia, here the mechanism is that glucose itself is acting as a diuretic, or it's causing diuresis. That's why their plasma volume is they're losing fluid from the plasma, but they're not using as much sodium. That's how their plasma sodium level is high. Diuresis, osmotic diuresis is the mechanism here. Pseudo hypernatremia, it's not the same as hyponatremia. So hypernatremia, it's usually because of free fluid loss, not because of changes in the how much sodium is, unless we give them hypertonic. In other cases, it wouldn't be because of sodium, it would be loss of free fluid. Moving on to the next question. Number 56, timer starts now. Dr. Gursharan, number 1. One is it. Okay. Dr. Gursharan, Dr. Paul. Okay, Dr. Gursharan, you can start the answer.
So it's A, start desmopressin.
Okay, Dr. Paul.
Yes. A, start desmopressin.
Okay. Does anyone disagree with them or want to add another medicine to it? Anyone? Okay, so we have a case of diabetes insipidus from how it is presented. Thirst with polyuria, and they now have hypernatremia, and their urine is still dilute despite hypernatremia, so it points towards towards loss of water, which is from the diabetes insipidus in this case. Once we give them desmopressin, their urine osmolarity becomes 520. Remember, I told you just a few minutes ago, in diabetes insipidus, if you give them desmopressin and their urine osmolarity rises dramatically, it is central. If it rises very little or mildly, then it is nephrogenic. Now, what is the next best step in treatment? Desmopressin, because they are deficient in desmopressin. We will replace in ADH. We will replace it with desmopressin. Okay. Any questions so far?
Sorry, what is tolvaptan?
Tolvaptan is it's an ADH receptor antagonist. It causes more water to get lost, to get excreted. Sorry. Tolvaptan is ADH antagonist.
Thank you.
No problem. Okay, moving on to the next question, number 57. Timer is started. Please raise your hands once you're ready to answer. Dr. Zubaida. Dr. Sneha, number 2. Dr. Gurshan. Dr. Sidana. Okay, 20 more seconds. Okay, Dr. Zubaida, you can start answering. Timer is up.
Option D.
D. Okay, Dr. Sneha.
Yeah, option D.
Option D.
Yeah.
Okay, Dr. Gulsharan.
Yeah, option D.
Option D. Are you sure?
Yeah, I'm sure.
Okay, Dr. Sidana. Option D.
The same D.
Okay, why not CIAD? Remember, pneumonias or hospitalization can cause similar things, right?
Yeah, because the sodium is high.
High. Okay. Good job. CIAD would cause hyponatremia. Remember, central DI wouldn't fit here because he didn't have any surgery of the pituitary, and urine is very concentrated. In DI, urine is dilute despite hypernatremia. Lithium toxicity will cause nephrogenic DI. It will again have urine would be dilute, not concentrated. Thiazide will have concentrated urine, but thiazide also causes hyponatremia, not hypernatremia. And the urine output would be high because their thiazide is causing diuresis. All right. Moving on to the next question. Correct answer would be D, insensible loss because of fever. Fever can cause sweating and increase the losses of fluids. Okay, moving on to the timer has started. Dr. Sneha. So whether Dr. Manisha, Dr. Kulshar, and Dr. Sidana. Okay. We started 15 more seconds. Dr. Sneha, do you mind if I let Dr. Manisha answer? She's been away for a
Yeah,
while.
sure.
Dr. Manisha, do you want to answer?
Yes, C as a cat.
Desmopressin test. Okay. Dr. Kushner, do you want to add something or do you agree with C?
Yeah, I agree with C because so the desmopressin test is used to distinguish between nephrogenic and central, and we give desmopressin after a period of water deprivation, and then C.
Right, and Dr. Sneha, do you agree?
Yeah, option C.
And C, okay. Mr. Zubeda, do you want to add something?
Yeah, there's the best. Do you want the best? It's the desmopressin, not because all of this mention about this.
Right. Serum ketone levels. Remember, this looks like a case of DI, symptoms-wise, presentation-wise. Someone producing large amount of urine and then with hypernatremia, we would think of DI or diabetes insipidus. If their urine osmolality is still low despite having high sodium levels, this raises our suspicious either higher towards DI, and low sodium in the urine that is being passed, which is large amounts, means that the kidneys are not absorbing enough water compared to the sodium that's being reabsorbed. Now, how do we differentiate nephrogenic from central DI? Central DI, if we give desmopressin, their plasma osmolality, their urine osmolality would jump very high. Nephrogenic, you give desmopressin, they will have minimal, mild, very little change in their urine osmolality. It still may rise, but it wouldn't be as dramatic rise as with central DI. Moving on to the next question. Timer started already. Okay, Dr. Gershon is the first to raise her hand. Dr. Sneha, Dr. Zabida, Dr. Manisha, Dr. Agnes. Okay, 15 more seconds. Dr. Kusharan, you can answer.
So I'll go with D, 5% dextrose.
Okay. Dr. Sneha?
Yeah, I agree with D.
You agree with D? Okay. Dr. Agnes, do you want to agree with D or do you want to add something here?
I thought I'll go with E.
You will go with E, dextrose 5 water.
5% dextrose water. Is that not what E is?
E and D are the same, 5% dextrose and dextrose
Okay.
water 5. Okay. Dr. Zubaida, what would you pick?
I think option B is because ringer lactate is osmolality is near to the serum.
Okay.
So
it's isotonic. Okay. I'm still waiting for the correct answer, unfortunately. Dr. Abudian, do you want to try this one? Yes, Dr.
No. I'm thinking of A as an apple.
A as an apple, why?
So because the patient is limited for IV or for water. So if we can give him or her IV fluid,
okay,
so it will help her.
Good job. Okay. Dr. Agnes, do you want to add anything else? The correct option should be A. Let's see what we have here. Because he has poor intake and his sodium is high because of the poor intake, once we give them saline, their sodium will jump back. But again, so saline and ringer lactate are kind of similar in what they do. 3% saline wouldn't be an ideal here because it's already hypernatremia. 5% dextrose and dextrose 5 water. They both, I think, mean the same thing. Let's see. Option E. Okay, let's see why it's option E. Dextrose 5 water is best because free water once glucose is metabolized directly addressing the water deficit, driving hypernatremia. The patient is stable, so you can focus on deficit rather than shock resuscitation. Dextrose 5 water distributes across total body water and low sodium gradually when it's given at an appropriate rate, which is the core goal in chronic or unknown duration hypernatremia. Especially to choose a hypotonic solution for free water replacement when there is no hemodynamic instability. Okay, I think dextrose 5 water is imprecise because the IV solution for free water replacement is D5W in the best. Okay, so option E was correct. I was wrong, but I would still choose saline in this scenario. I will confirm it and then post it in the WhatsApp group because this is related to low intake. It's not because of taking more sodium. Let me look it up. All right, let's move on to question number 60. Timer is started.
I did not watch the
Socks.
socks yet. It's hanging on the chair. And this is for just in case I know that.
$15 more seconds. Dr. Sneha, you can, you can go ahead and answer the question.
Less than 10 according to age. But I'm confused. It can be less than 12 as well, but I go for less than 10.
Less than 10, okay. Dr. Gursharan?
I think we should go lower, less than 5 millimole.
Less than 5, okay. Dr. Stella?
E, lower 10.
10 millimoles, okay.
Yeah.
All right. I think 10 should be the correct answer, right? Since it's an elderly, we cannot lower more than 10 at once. Let's see. Yeah, the correct option is B, but that's wrong. If you look at the explanation, lowering by about 10 or 24 is the safest target. Okay, so correct option should have been E, but because of some issues, it's been chosen as B. Dr. Sneha and Dr. Kurshan, I think you were right. So it's 10 millimoles. You cannot lower faster than that. Especially if it is someone who is 90 years old, we would even target for 8. We can, timer started now. Let's try to finish 5 more MCQs before we sign off. Dr. Agnes, do you want to answer? Your hand is still raised. Dr. Gursharan, Dr. Agnes' hand has been raised since she wants to answer. She can raise it. Dr. Sneha, Dr. Zubaida, 20 more seconds. Dr. Manisha, okay. And Dr. Kusharan, you can go ahead with the answer.
So it is D.
D?
Yeah.
Okay. Dr. Sneha?
Yeah, I agree with D.
Okay. Dr. Zubaida?
The patient is a hypernatremia, and I will go with option C. Bravo.
Okay. Do you mind
Hypotensive. Oh,
reading the
sorry.
symptoms again?
Yeah, it's hypotensive. So yeah, option D.
Option D. He's
Yes.
confused. Remember, for confused people, we don't give them oral fluids.
Yeah, yeah.
Dr.
It's
Manisha?
also yes. Thank you.
Yeah, no problem. Dr. Manisha?
D as a doctor.
D as in doctor. Okay. Does everyone else agree? Okay, I think the correct answer should be D. Goal here would be resuscitation. Best fluid to resuscitate someone who is hypotensive and tachycardic and confused is normal saline. Unless their sodium is very, very high, in that case, we can consider other isotonic fluids. Let's move on to the next question. Yeah, D is correct. Timer starts now. Okay, Dr. Sneha, Dr. Gursharan. Let's get someone new to answer. Dr. Agnes. Those who haven't answered yet, do you guys want to try? Dr. Marcel, do you want to try this one? Dr. Qais? Okay. 15 more seconds. Dr. Sneha, you can go ahead with the answer.
Option A.
Option A, okay. Dr. Gursharan?
Yeah, option A.
Okay. Agnes?
A.
A. Dr. Zubaida?
A.
A. Okay. I saw Dr. Stella's hand was raised. Dr. Stella, do you want to?
Yeah, it's A.
It's A. Why is it A, not B, C, or D, E? I want you to rule out the other ones. Why they are not correct?
It's A because the urine osmolality remains low despite there's no percent.
Okay. Sure. Now, why isn't it C? Dr. Agnes?
Okay. Can I answer it?
Yeah. Dr. Agnes, your hand is still raised. Sorry.
So if it is C, it would be hyponatremia, not hyper.
Hyper. Okay. Good job. And why not D? Dr. Sneha, do you want to remind us why D is wrong here?
Oh, the urine osmolarity should be more than 100.
Urine osmolarity would be more than 100. And okay. So osmotic diuresis is seen in what condition?
Diabetes.
Diabetes. They will have hyperglycemia. It's not mentioned here. So if it's not mentioned, it's not there. Why not pseudo hypernatremia? Once again, it's the same thing. We already discussed that. Let's move on to number 63. Okay. Timer starts now. Dr. Sneha is the first one to raise her hand. 40 more seconds. Dr. Zubaida, second to raise the hand. 30 more seconds. 15 more seconds. Dr. Sneha, you can answer now.
Option B.
B. Okay. Dr. Sabzaveda?
Option D.
D. Okay. Dr. Manisha, do you want to add something here? We're missing Dr. Homa. Dr. Homa, are you here? She isn't here, I think. Okay. Dr. Sneha, why did you give them thiazide? It's a diuretic. It's going to make them pee more, right?
I believe this is the first line of the treatment. So.
It is first line treatment. Okay. Does someone know the mechanism how thiazides work in nephrogenic DI?
It reduces the urine volume.
Urine volume, okay. But how does it reduce it?
Reabsorption of any like sodium from distal tubules.
Thiazides reabsorb sodium from distal tubules, okay. Dr. Mahbuba?
Because I think in nephrogenic DI, the kidney is resistant to the ADH, and it prevents the concentration of the urine.
Okay.
Yeah, that's the mechanism, I think.
Okay. You're partially right. Dr. Stella was very close to it. The mechanism is quite complex for how thiazides help with nephrogenic DI. There are several mechanisms, but one mechanism is that thiazides actually lower the volume of plasma, or the amount of plasma, or the amount of serum that's being filtered. So this is how they help reduce urine production, excess urination in nephrogenic DI. Okay, next.
Dr. Vance, can you please explain this mechanism?
Yeah, so what happens is when you give them thiazides have kind of, like it's explained here too, that's a paradoxical effect. So what thiazides normally do is they cause diuresis. But by diuresis in someone with nephrogenic DI, it causes the extracellular volume, or the plasma volume inside the blood vessels, to come down or contract. So since the plasma volume is contracted, this stimulates sodium reabsorption, and it also reduces the amount of blood that's being filtered. That's how it works, by reducing the plasma volume, not by making ADH more sensitive or by making the receptors work.
Thank you.
No problem. Okay, second last question for tonight. "15 seconds done." Dr. Agnes is the first one to raise her hand.
A.
Dr. Sneha is second. Dr. Gursharan. 20 more seconds. Dr. Manisha, number 4. Okay, Dr. Agnes, you can answer now.
Yeah, A.
Option A, okay. Dr. Sneha, why is it A?
There will be rapid shift of water like from the brain towards the from extracellular to the intracellular. So.
Okay. And when will B be the correct answer?
Hyponatremia.
Hyponatremia. Okay, good job. Dr. Gursharan?
I think it's B, pontine demyelination.
Pontine demyelination. Why not A?
I think a rapidly correction of hypernatremia, if you do it too rapidly, it leads to osmotic demyelination syndrome.
Yes, you're
It
right.
affects the pons.
Is that correction of hyper or hyponatremia?
Hyper.
Okay. Dr. Manisha?
I'm a little bit confused, but I think B is correct.
B is correct, okay. Dr. Sneha, do you want to explain why A is correct and not B?
This is a hyper condition, so usually there will be shift of water into the brain, like from the extracellular to the intracellular. So that is, and for pontine demyelination, it is just opposite one. So
Good job. So here it's hypernatremia. Remember, in hypernatremia, deficit of fluid is intravascularly. So when you give them fluids quickly, what happens is the sodium corrects quickly. The intracellular is now more concentrated compared to the blood vessel. The water goes from blood vessels to intracellular or to the extracellular space. That's where the cerebral edema happens. In hyponatremia, it's the opposite. So in hyponatremia, the blood vessel is less concentrated compared to the extracellular. Once you start concentrating it, you concentrate the plasma or the serum inside the blood vessel. The extracellular or the fluid inside the brain or the cells, it is still the same. Now what happens is concentrated fluid pulls water from these cells, and that's how that injury happens. It's kind of opposite of each other. Rapid volume or sorry, a rapid correction of water deficit, edema. Rapid correction of sodium deficit, demyelination. I hope it helps. So let's move on to the next question. Timer starts now. Okay, first to raise hand is Dr. Zubaida. Okay, Dr. Manisha is number 2. Dr. Agnes is 3. "25 more seconds." Okay, Dr. Zubaida, you can answer the question.
Option B.
Number 4. Sorry?
Option B.
Option
B
B?
as a B. B as a baby.
B as in baby. Okay, Dr. Manisha?
E as an elephant.
E as an elephant. Okay, Dr. Agnes?
Yeah, D and E are the same thing, so I'll go for E.
Correct, 10 daily replace deficit 24. Okay, option E. Dr. Sneha?
I go for B.
You want to go for B. Okay. Dr. Sneha, do you want to read the duration of the symptoms? Forgets dosage for 1 day and develops symptoms of thirst, polyuria, and serum sodium raises to 151 within 12 hours.
12 hours.
It's acute, so we can correct it in 24 hours. Since sodium level is 151, it is only 6 above the normal, which would be 145 cutoff. So we can correct it within 24 hours by giving them free fluid, which would be dextrose water. All right?
Yeah, thank you.
Okay. I'm going to stop the recording.